Hey everyone, can progesterone decrease the risk of miscarriage? In infertility treatments, we see patients go through very difficult journeys. There's so many different unique obstacles that are presented in a fertility journey for so many patients. And I find that while there's a lot of underlying common factors, um, the experience of infertility and how each couple confronts all of the different obstacles is quite unique from couple to couple. And going through that process, all of that investment, your emotional investment, financial investment, when we finally make it to the payoff, which is having a positive pregnancy test, the shift changes very quickly from trying to get pregnant, obviously, to what are all the things that we can do to help reduce the risk of miscarriage, to help maintain this incredible result that couples have worked so hard to get to. And so, a very important component of what we look at with miscarriage prevention, among other things, is progesterone therapy. And there were studies published, small studies starting as early as 2000, I believe 14 to 16, we started to see more. And a couple of years ago, we had a couple of really good systematic reviews and meta-analyses look at this subject as well. And now we've had two new, very high quality studies also evaluating for this in the past 2 years. And so we have new research and a new review looking at, how does progesterone help reduce the risk of miscarriage? Who does it help reduce the risk of miscarriage for, and how significantly does it reduce the miscarriage risk from a more numbers perspective? Like, what are the percentage benefits to taking progesterone as opposed to not taking progesterone? And so it's very important to discuss this because I find once patients make it to this point, they're unsure of what to do. A lot of them aren't explained, what the risks of miscarriage may or may not be, and some unfortunately have gone through multiple miscarriages, so are very well aware of the risk of miscarriage and are, actively looking for treatments or therapies to help reduce this risk. So it's important we first of all differentiate miscarriages into two categories. So the first category is what we call aneuploid miscarriage. Aneuploidy is an imbalance in the genetic structure of the embryo or the fetus. So it means that there is either too many chromosomes or too little chromosomes. Usually it's a trisomy, meaning we have an extra chromosome. And this can become an issue, obviously, and a majority of aneuploidy pregnancies do lead to miscarriage because the genetic material is simply unviable to support a pregnancy. Um, and that's for the majority of cases. Now, the risk of an aneuploidy miscarriage, it's thought to be a result of a random error during the gamete process when the gamete matures, so the sperm cell or the follicle or egg cell, right? And the risk of having an aneuploid miscarriage doesn't increase with future pregnancy. So if you have one miscarriage, your chance of having a second aneuploid miscarriage doesn't go up. It usually stays consistent. The second type of miscarriage that can occur is what we call the euploid miscarriage. And a euploid miscarriage is when the genetic material is actually fine. There is a perfect balance of the number of chromosomes. So it's usually related to other factors such as hormone imbalances, um, autoimmune conditions, and other factors where stress, nutritional deficiencies, all these things may potentially have a role. So the main one is what we call luteal phase defect. That's one of the main risk factors where a new mother is having difficulty producing sufficient amounts of progesterone. And so therefore we need that progesterone to maintain the decidua in the uterus and to support the pregnancy and help carry it to term until labor. So when progesterone is low, the miscarriage risk tends to go higher. So what we've seen in this new review published recently this past month that evaluated for two new studies and previous studies is that using progesterone may help reduce the risk of miscarriage for patients. The patients that seem to respond the most or see the greatest improvement in miscarriage reduction are patients who've had 3 or more miscarriages in the past and have presented to a doctor's office with active bleeding during their first trimester. So they're already having early signs of potentially another miscarriage. And so women who've had 3 previous miscarriages, and if they use progesterone, the chances of them carrying to term with a healthy baby are usually 75%, or sorry, 72%. And if they don't use progesterone, and instead, if we gave these patients placebo, their chances of carrying to term with a healthy baby is about 57%. So it's a significant increase in your chance of carrying to term with a healthy baby for the patients who've had 3 or more miscarriages in the past and are presenting with active bleeding. And so we see that improvement in live birth rate goes down a bit when you've only had 1 miscarriage. So patients who presented with active bleeding but have only had 1 miscarriage in the past, overall, on average, had about a 75% chance of carrying to term with a healthy baby. And if they didn't use progesterone when they presented to the healthcare provider's office and were instead given a placebo, only had a 70%, so about a 5% increased chance of carrying to term with a healthy baby if you use progesterone in those cases. So the biggest issue with who should we give progesterone to is really on an individual case by case basis. And this is because, even though the risk seems to be, the benefit of using progesterone can be small to great, it's an independent conversation that needs to be had with the patient. And it's important to mention both of these new studies couldn't find any side effects from using a vaginal suppository with progesterone. So it was specifically a suppository that was used. They're not using injections in these studies, and it was micronized natural progesterone. So when we look at, patients who come out of fertility clinics and have had a pregnancy test, usually they're told, well, we did the blood test, the progesterone level looks fine, therefore you don't need progesterone. And what I always explain to patients is the level of progesterone in the blood goes up and down very quickly in the blood when checking serum values. So it's something that's quite unreliable, and the diagnostic and prognostic value of something like a progesterone blood test is quite poor in determining if a patient's going to have a miscarriage or if they have something called luteal phase defect, which is insufficient progesterone production in the luteal phase or once pregnant. So we really can't rely on that blood test to say if a patient, has good progesterone or not, because it might be on its way up and down. We really don't know what the average is. And salivary progesterone has the same issue. We don't know the exact diagnostic and prognostic value of taking something like salivary progesterone, which is a common test prescribed by certain healthcare providers. So really what it comes down to is a case-by-case basis and discussing with the patient what the known benefits of progesterone are for them. So based on their health conditions, based on, if they have significant spotting before their period, if they have a short luteal phase, usually 12 days or shorter in cycles prior to getting pregnant, and also looking at, the history of miscarriages. So if a patient has had 1 or more miscarriages, there's potentially, significant benefit to using something like a progesterone suppository, especially when it has such a high safety profile. And using progesterone for first-time pregnancies, while the benefit may be very minimal, like 2 to 3% improvement in live birth rates, it's still significant considering patients work so hard to get to this point, and the risk of taking progesterone is usually so low. So it's important to communicate that using a blood test to measure your progesterone once you're pregnant isn't usually enough, and it's not a good idea to rely just on that to say, okay, I don't need progesterone anymore. And so you should be having this discussion with a healthcare provider. We always have this discussion with patients once they're pregnant, and when needed, we prescribe the progesterone to help protect that pregnancy and help support those patients.